So, tell me when we're on.
We're on.
Are we on?
Yeah, we're on.
Okay. All right, good morning, everybody. I'm Hugh Kraft. I've been at Carilion for a very long time. I'm currently working at the Postal Drive office. And I want to give a shout out. Mike Hart is usually tuned in, and I actually saw Mike a few months ago at his home in Myrtle Beach. So Mike, if you're there, good morning to you. I have a very large task this morning. It's not going to take much time. I have to get y'all ready for the main attraction, which is Dr. Keele. I'm kind of the warm-up band for the Rolling Stones. And what we're going to talk about today is the concept of informed consent and how it's evolved into what we now call shared decision-making. And I have no disclosures. My objective is to describe the modern development of informed consent and the concept of shared decision-making. And this is the look that my lab gives me when I'm working on grand rounds early in the morning, and she knows that it's time to go walking. So she just kind of sits there and waits till I put my socks on and get up and get going. The doctor-patient relationship, if you look kind of going back to antiquity and probably the Hippocratic periods, that's when we first have any kind of written record. And up to about the beginning of the 20th century, patients sought out physicians and healers, and there were a lot of healers that weren't physicians. If you kind of get back into the history of medicine, there was a lot of healing going on that wasn't being done by doctors or in doctors' offices. To diagnose them, to treat them, to heal them, and to comfort them. And the relationship in terms of decision-making was decidedly one-sided. Physicians really had the decision-making authority. There was not really any informed consent or negotiation or much explanation. The patients came to see physicians, and physicians told them what they were going to do. And there was actually a lot going on back before the beginning of modern medicine, which I would kind of date late 19th century, early 20th century. Patients were bled regularly. And even the great William Osler, who practiced until early 20th century, he was still bleeding patients around the turn of the 19th to the 20th century, even though it had been shown for decades it didn't do anything because he couldn't give it up. And I think it's a great example of how hard it is for us to change the way we've been doing things for years and years and years. And a lot of other things were going on, purging and clistering. Clistering's kind of the old-timey term for an enema. Cupping and blistering, a lot of amputations, removing bladder stones without anesthesia, cataract removal going on 1,000 years ago. Fractures were being set, wounds cauterized, boils lanced, all sorts of oral things were concocted. If you get back into kind of the ancient materia medica, all sorts of things were devised in ancient pharmacies and by old apothecaries and various topical treatments. And the remarkable thing about most of these things is they really did nothing. Setting a fracture accomplished something, lancing a boil accomplished something, but most of the things on this list really didn't do anything. Some of them may have actually hastened the patient's demise. And then in the early 20th century, the courts got involved. And there were really very few court decisions prior to 1900 that dealt with consent issues, but there were 4 cases in the early 20th century that really set the wheels in motion for establishing the requirement for a patient's prior consent before performing surgical and other types of procedures. I'll touch on a couple of these. Anna Moore consented to surgery on her right ear. During the course of the procedure, the surgeon determined that the left ear also needed surgery, and he operated on it. But she sustained hearing loss in that ear, and she sued him, and the court found that the doctor should have obtained consent before operating on the left ear. And that's really one of the first cases that kind of, began to lay out the groundwork for what has become informed consent. And in the Moore opinion, these early court decisions, you can tell which the justices that were probably English majors, because their prose is just, it's really a thing of beauty. The free citizen's first and greatest right, which underlies all others, the right to himself or herself, is the subject of universal acquiescence, and this right necessarily forbids a physician or surgeon, however skillful or eminent, to violate without permission the bodily integrity of his patient by major or capital operation, placing him under anesthesia for that purpose, or operating without his consent or knowledge. And that's the first case that really kind of laid out clearly what has evolved to become the doctrine of informed consent. And then the second case, which is really even more widely quoted, was Schondorf versus the Society of New York Hospitals. This was in 1914. Mrs. S. consented to an abdominal examination under anesthesia, but specifically requested no operation. The surgeon proceeded to examine her and actually did a hysterectomy. And Judge Benjamin Cardoza, who's really a widely respected jurist at that time and moving forward, his opinion included the statement which became the most widely quoted elaboration of the patient's right to self-determination. And he was so well thought of, he actually made the cover of Time magazine sometime later. Every human being of adult years and sound mind has a right to determine what shall be done with his body, and a surgeon who performs an operation without his patient's consent commits an assault for which he is liable for damages. And Cardoza's right to determine is really kind of where the essence of the doctrine of informed consent has been founded on. We have a right to determine what, as free citizens, what is done to ourselves. And that would evolve into what became the key concept of patient autonomy, which developed really much later in the 20th century. And then post-Schondorf, courts in multiple jurisdictions decided cases citing it and some of the early 20th century cases, and they used battery and negligence as the foundation for the decision. And then in 1957, a patient named Martin Salgo underwent a procedure at Stanford University Hospital, which left him paralyzed below the waist. And he sued the hospital, and the California Court of Appeals found that a physician could be liable for not disclosing relevant information to the patient, and wrote that a physician violates his duty to his patient and subjects himself to liability if he withholds any facts which are necessary to form the basis of an intelligent consent by the patient to the proposed treatment. And this is kind of where the term informed consent evolved from, was this case, and there was actually a case subsequent to this also. So you can see this is 60 years old, and we're still wrestling to some degree with what informed consent is. And then I wanted to touch on the research side of this, because these cases dealt with patients and physicians and procedures being done. But there's the whole issue of informed consent dealing with research subjects too. And I talked about this last fall. Henry Beecher is an anesthesiologist at Harvard, and he published a paper in the New England Journal in 1966, which looked at, he found at least 50 cases where patients had things, or where subjects had things done to them with either no consent or very questionable consent. Well, one example was the Willowbrook Hall hepatitis study. That was a home for children with handicaps, disabilities in Illinois, and some investigators decided, well, why don't we use them to see what the natural course of hepatitis A is? So they just infected these children with hepatitis A, no parental consent. Hard to believe in this day and age, but he had other cases that were as egregious as those. And one of the things his paper pointed out was how much money was involved directed at research at the time of his paper, as opposed to just 20 years earlier. Massachusetts General Hospital got $500,000 in research funds in 1945 and got over $8 million in 1965. And then you look at the NIH budget in 1945 and look at the NIH budget 20 years later. And so there was this tremendous outpouring of money to do clinical research. But appropriate consent to protect people undergoing clinical research did not really evolve quickly enough. And then Salgo, getting back to that case, informed consent had been has primarily evolved in the legal system. And the early cases in the 20th century were actually based on battery, assault. But plaintiffs' attorneys wised up and they started using it more and more for negligence. And that's really where kind of the whole medical, legal complex, there's so much money floating around and at risk and being made with litigation against physicians, particularly early on where the informed consent was either lacking or completely inadequate. So really the courts have kind of forced this more than the medical profession has. And then post-Beecher on the research side, it's interesting, informed consent really changed very little until 1972. And that's when a reporter got tipped off about the Tuskegee, Alabama syphilis study. And when that was exposed, Congress passed the National Research Act, and that contained establishment of the National Commission for the Protection of Human Subjects. And that commission really pushed forward the agenda for establishing adequate protection for individuals who are involved in medical research. What else was going on in the 60s? Anybody? I know most of y'all weren't around then, but what kind of social things were going on in the 60s?
Vietnam, race wars.
Yeah. The war in Vietnam.
Hippies.
Yeah.
Free love.
Free love. The pill.
Sexual experimentation.
Civil rights, women's rights, assassinations. I mean, the 60s there was a lot going on. And then you get into the early 70s, Roe v. Wade was passed, which has subsequently been overturned. And then medically in the 60s, I mean, the advances in research and your doctors actually be able to do things that help patients. The 60s is when it really started to take off because research started to reveal what things worked, what things didn't. And so the ability of physicians to actually to treat and cure and alleviate conditions really advanced in the 60s. And patients demanded more say, started to demand more say in what was done to them. That was the other thing that came out of this period of time. And so the origin of the concept of shared decision-making is that these two statements are taken right from the President's Commission report, which, if you want to read it, it's 6 volumes. But it's full of really classic pieces about, that deal with this whole area. Ethically valid consent is a process of shared decision-making based on mutual respect and participation, and not a ritual to be equated with reciting the contents of a form that details the risks of particular treatments. And so that's really the origins of what Dr. Keele is going to talk with us about next.
Oh, it's a good thing I'm long-winded. You did not take much time at all. Okay. Oh, you have.
Oh, if you're curious.
If you're curious.
Yes.
Some suggested.
If you really want to get into this, Katz's book, which is almost 40 years old, and Rothman's book, which is a little more recent, those are absolute classics about kind of the status of the world and the physician-patient relationship at that time. And it's really interesting to read those and kind of reflect on what's changed and what hasn't.
Awesome. Okay, so I'm going to take over shared decision-making. These are my objectives. Really talk about some different, kind of what goes into the different models that exist for shared decision-making, clarify the physician's role, and to understand how family values should impact shared decision-making. So I probably titled this slide wrong because it's not why I care, but it's what kind of prompted me and Dr. Kraft to kind of get together and do this was some things, we had talked about his interest in informed consent, and both of us have some bioethics training, probably a little more on your side than my side. But I've been on several bioethics committees in other institutions. And so it's always been an interest of mine and a passion of mine. But in the ICU, we face a lot of ethical decisions and moral decisions, whatever you want to call it. But we had a case where we had a little 5-year-old who was in a really horrible motor vehicle accident. Her mother passed away at the scene, and she was very, very, very injured, so very severe head injury. And of course, our neurosurgeons got involved in the case, as you would expect them to. And she had a bleed on one side, and so a hemicraniectomy, so removal of part of the skull, is completely normal and routine in some of these situations. This little girl continued to have really, really high, out of control intracranial pressures. And so despite it not being standard of care, the decision was made to take her to the operating room and do a bilateral hemicraniectomy. And I wasn't there for the discussion, but it was relayed to me a statement of, they went to the dad and said, well, we can do this, or she can die. And so dad, of course, said, do everything you possibly can. And she survived. She absolutely survived. She survived completely neurologically devastated and is in an institution because dad can't take care of her. And she doesn't do anything. She doesn't interact with her environment or anything like that. And this is why bilateral hemicraniectomies are not necessarily standard of care, is they found that doing these to people would absolutely increase survivability. But the neurologic outcomes were not necessarily the good balance for surviving. And so we had another case just after it where I was the attending on, and one of the neurosurgical attendings said to me, well, we can, I wanted an EVD placed, already had a unilateral hemicraniectomy in this patient, but we had no way of monitoring. So I said, please put in an EVD for me. It'll help me control ICPs. And I was told, yes, we can do that. Next step would be a bilateral craniectomy. And I said, no, there is no other step. Like, you guys are done with your part of it. And she said, no, if the parents want it, we will do it. And so, in discussion with some people, the term shared decision-making just kept coming up. Well, this is shared decision-making. This is shared decision-making. So I just really thought, I'm like, there's a chance that some of us are misunderstanding what shared decision-making actually is. So I wanted to delve into it and look into it a little more. And I've learned in exploring this topic a lot of things that I didn't know about this. And so Dr. Opal from Seattle Children's, and he actually, we'll go through this framework that the AAP has for pediatrics, and this is one of the statements he made: as many decisions that should not be shared with parents are, and those that should be are not. So we still have, just as Dr. Kraft said, even though this has been going on for decades, we're still not really great at this. So again, this was a bioethical move away from paternalistic medicine, as already has been described by us today, and really the emphasis behind it is these bioethical principles of doing the right, doing the best thing, not causing any harm, giving our patients or families a lot more autonomy. So the first models date back for shared decision-making, date back to the late 1990s. Originally just an exchange of options with risks and benefits, but also starting to pull in families' values and preferences. And that's what makes it different than informed consent, is you're actually taking into account their preferences and values. Most of the models have defined experts, so the healthcare providers would be the experts of the medical opinion, but adding to it the experts of our patients or their families. They're the experts in their values, their preferences, and there's some essential elements which we all are used to with informed consent, which is defining and explaining the problem as well as you can to families in a way that they'll understand it, making sure you discuss the pros and cons and any alternatives. But in addition, we start adding in this discussion of patient values and preferences, and then some models, it was interesting, especially the earlier on models, said that you actually cannot finish shared decision-making until a decision is made. And now they've moved a little bit towards, sometimes these discussions and shared decision-making is really just a time to sit down and chat and give people time afterwards. So I briefly wanted to go through, so there was a recent systematic review of all of these different shared decision-making models that exist. And I thought some of the information that they pulled was pretty interesting, so I'm going to whip through that pretty quickly. But they covered 40 articles. 12 of the models were generic, meaning that they could be applied to almost any medical decision that needed to be made. 28 of the models that they looked at were very specific, so whether it was like cancer treatment or antibiotics for otitis media, they were very specific to a specific group of conditions or patients. And then of note, half of the models were published in 2015 or later. So even though they started in the 1990s, of course, there were just a few models that initially started, and then since 2015, there's been a really big uptick in how many models are being created. So hopefully you guys can see this. These were just some of their overarching components that they found in all of these, shared decision-making models. The dark blue part of the circle is the part that in most of these models is the responsibility of the patient versus the lighter blue, which is the patient and the healthcare provider, and the dark green, or the greenish one, is the healthcare providers. And I thought it was really a fascinating visual because there's still a lot of green in most of these different concepts. Very little of it. I would say patient preference is probably the only one that is a little bit more blue. But you can see that even healthcare providers play a role in patient preferences, which I thought was really interesting. And we can talk about that later, but my guess, I don't know why. I mean, I don't know for sure if this is it, but, sometimes what we have to say actually influences patients' preference. I think most of us have probably had somebody sit in front of them and say, well, what would you do? And I think when you answer that question, you're helping to somewhat influence their preferences. So then they actually just looked at the changes in some of these models over time. So I'm going to whip through a bunch of these. I think they're really interesting. You can see at the beginning of the graph, it's up to 2010, and then over the next 8 years. Just some of the differences in the focus of the models that had been developed over time. You can see, at least on this one, treatment options has always been really high, and it remains high, but some of these other variables have changed over time. This one was looking at how deliberate the discussion was, how much time was spent learning about the patient, and you can see that where the newer models are much more focused on spending time learning about the patient and the families. This one, patient preferences has gone down, which I find really interesting. And the focus on the healthcare professional preferences. You can see that started at like 40% of the models had that a really high component of them, and that has gone significantly down. Maybe as we're learning to do this, we put our own preferences in a little bit less. And then this would be like models that are either meant to just determine your next step, offering more time, reaching mutual agreement, or definitely we need to make a decision at this. And they, according to them, they found that most models are actually leaning towards making a decision. And then in this graph, I threw this one in because it looks like the first models were focusing on who, determining the roles and how you make the decision process, and that has gone to, completely gone away. But this concept of choice awareness has been pretty prominent in the models. And so I wanted to talk a little bit about what choice awareness is. So they define it as acknowledging that the patient's situation is mutable, so there's different options that can change. And there is more than one sensible way to address that. So in this article, they talked about how this has been put forward as a pivotal step in achieving shared decision-making. And it's included in most models, just like we saw in the last graph, but it's actually seldom seen in clinical practice, which I was like, that's interesting. I would think that that's exactly what we're doing, is saying, oh, there's different options and that will impact what the outcome is. But they're saying it's rare, seldom seen. So this is just a brief summary of everything that they found in this study of looking at all these models. They talked about the importance of describing your treatment options, but emphasized that just because you describe it and give them all the information, it doesn't mean that that particular time you're doing this, they can actually grasp or utilize that information or be able to participate in shared decision-making at that point. The importance of reaching mutual agreement, really the focus is that this is a shared process and you need to take some time. And there's been a movement away from healthcare professionals' preferences, and I alluded to this, some patients actually want your recommendations. They want to hear what your preference is, and it actually, in general, will sometimes help them. But I think you need to have spent enough time with the families to really understand whether or not you're going to be for lack of a better word, manipulating them towards your preference, or just actually trying to help them make a decision by stressing your importance. So I found this great framework, 4-step framework for shared decision-making in pediatrics. As we know, shared decision-making with an adult patient is going to be very different than shared decision-making with a child. And so there's different models that are designed for pediatrics versus the plethora of adult models. So I thought it was really important to go through this and talk about the different steps in this particular framework, because I think it really teases out what's difficult about shared decision-making and why we might not do it really great. So this is the model. It has 4 different steps. We're going to go through each one of these and talk about it. The first one is, does the decision include more than one medically reasonable option? And if the answer is no, then they say this is not shared decision-making. If it's yes, you move on to step 2. So we're going to go through step 1. So if only one treatment option exists, then it's more physician-controlled. It's a little bit more close to what we would define as informed consent versus shared decision-making. So it's really, this is the only thing that we can possibly do. And so I'm going to tell you all about it. I'm going to tell you about the risks, the benefits, And the assumption really is that you're going to convince them to do what you think is the only real medical option. So, for instance, the example that they used was if you had a patient with an asthma exacerbation. Are there multiple options for treating that in general? They argued no. Like, we would do steroids and albuterol to treat an asthma exacerbation. And so they said you wouldn't spend a lot of time sitting down with the family trying to figure out where their values and preferences were. You would just say, this is the treatment, this is the risks, benefits, this is what this medication is going to do, these are the side effects, this is why I think it's really beneficial and why we have to do this. So this is how we're going to treat your child. And so you can actually take time to discuss why there's not any really viable alternatives in this kind of a situation. But the interesting thing is even in this, where there really is just one treatment option, there are options within it, right? So let's talk about your steroids. So do they want prednisone, which is dosed very differently than Decadron, right? Prednisone you have to take 1 to 2 times a day versus Decadron, a dose here and a dose a couple days later, or not, whatever you want to do. So that's going to be different, and that part of that decision actually could be shared decision making. Same thing with albuterol versus Xopenex, if you have both of those at your fingertips. So that even in some of these decisions where there's only one viable option, there's sometimes a part of it where you actually could practice some shared decision making and give them a little bit more say in what's going on. Oh, I forgot that I left that in there. Okay, so the key thing here is that you have to be sure that the options really are options in order for it to go down that shared decision making model. And so they said that real choice is a prerequisite. So what does real choice mean? And just threw in that same definition of what shared or choice awareness was that I shared earlier. But so if there are more than one option, you have to ask yourself, okay, are they equal options? Do both options actually meet standard of care? Is there more than one option that actually produces the same outcome, or are you going down 2 totally different paths? Is it that there's more than one option that will be reimbursed or versus one that won't be reimbursed? So it's really difficult about what this, really like equal, medical choices are. So they defined real choice as 2 or more medically reasonable choices, and the medically reasonable choice they defined as being consistent with standard of care. That being said, there's still some issues with this because there may be parts of the decision with only one reasonable option. So for instance, and this is what I just described, using an antihistamine for mild seasonal allergies. You either don't treat your allergies or you treat them with an antihistamine. But again, within that you have options of when do you want to treat it, how often do you want to use it, things like that. But another issue with standard of care is there's not always consensus about what standard of care is. So they use the example of surgical intervention with patients with trisomy 13. There's not really a consensus. Some people think that you absolutely should, and there's a whole group of people who think you absolutely should not. So there's not a true consensus on this topic. What if the standard of care is not evidence-based? That we face this all the time in pediatrics because a lot of what we do, some of it is evidence-based, but it was evidence-based in adults, and we're just kind of extrapolating it to apply to children. And so, who knows? I always think of the example of, I have we treat ARDS in the ICU, and a lot of the treatments that we have actually been like, nitric oxide. It's actually, it's there, and it's part of a guideline, but it's not to be used on every single patient. There's not really good evidence that you do it, but I'll tell you that if you have a really sick ARDS, if I have a really sick ARDS and I've just sat there, I've done everything except nitric, one of my partners is going to say, did you try nitric oxide? Even though it's not recommended for most of the patients because it's just not been shown to work. So, but it's still considered, I think, a standard of care. Would you agree? So, okay. And then again, physicians' own biases and values still influence what we may present as reasonable, as medically reasonable. And I will, for instance, so the example I'll use is hypoplastic left heart. There are some forms of that anatomy that have really poor outcomes that in other countries would never be offered surgical options. They just immediately, when they see that anatomy, they go down the route of palliative care. In our country, very few of our CT surgeons ever bring up palliative care or the option to not actually operate on your child. I've worked with a lot of CT surgeons, and they're always on that side of we'll do surgery, and I'm always on that other side going, did you offer them palliative care? Did you offer to do nothing? It's an argument I've had with many, many CT surgeons. So our biases definitely get in the way, and you have to be really cognizant of that. Okay, so we're going to say that we do have a situation where our decision has more than one medically reasonable option. So now we're going to move on to step 2. Does one option of the 2 or more available have a favorable medical benefit or burden ratio compared to the other one? So is one a significantly better choice even though both exist? And so we're going to talk about that. So the rationale for this step, they say, was to fulfill the physician's obligation in pediatrics to ensure that surrogate decisions promote the child's best interest. Have you ever been in a situation where parents do not have their child's best interest at mind?
Mostly because they don't know or don't understand, I think. I hope.
Sure. That's a really optimistic viewpoint of the world. I wish it were true. But yeah, it happens. So I think we have time. I'm going to share another story. In California, adopted a right to die legislation right as I was a brand new attending. And it took a while for the hospitals to realize that the way the law was written was everybody was automatically opted into this policy. And so several hospitals started scrambling because I practiced in Central California, which is a very conservative religious part of California. It's very different than the coastlines. The hospital I was working at, panic stricken because their board of directors was like, oh, no, we will not. It was a children's hospital. So I was asked to come and speak. And I shared this story and had everybody crying, and then they still voted against me. But I had a situation where I had at Cincinnati Children's, where I practiced, where I trained, we had a 24-year-old man. Cincinnati is a big cancer center, and so a lot of young adults who have childhood cancers like leukemia end up being treated at Cincinnati Children's, even though they're adults. So 24-year-old in the PICU, and he was dying. He had systemic fungemia. His nose had pretty much rotted off. His digits were rotting off. He was not going to survive. And his parents left for church one Sunday. And his nurse came into the room and he said to her, I know I'm dying. I'm not going to survive this. But my parents are not going to let me go. But all I want, I need one last beer, and I want to see my dog. And he's like, no, that's all I'm asking for. Can you please make this happen? And so the nurse was like, absolutely, we're going to do this for you. And so then parents came back, and mom caught wind of it, and mom said, absolutely not. If you give him those things, he is going to give up and stop fighting. And it's a children's hospital, and we are very used to listening to parents. So even though there was a 24-year-old human who had every right to make his own medical decisions and was capable of making his own medical decisions, he died without ever seeing his dog another time and without his last sip of beer. And I use that example in this horrible situation as, a way to just say, we all think when we're in those situations, we are going to make decisions that are in the best interest of that person that we're deciding for. We're their surrogate medical decision maker. We're going to do right by them. But until you're in that situation, you have no idea how difficult that is. And we think, even those of us that are the best intentioned, I am sure that mother had the best intention. She wanted her child to survive. So even those of us well-intentioned are really bad at making decisions for other people. And I think that is something we see in pediatrics all the time, where these parents are well-intentioned. Even if you fully inform them, they know what they're looking at, they still have a tendency to make bad decisions because they're doing it for somebody else. In this step, if there is a highly favorable option of the two, then it goes towards this physician-guided shared decision-making. If there's not, if they're very equal and there's really not a better, neither one has benefit burden ratio difference, then it heads towards more parent-guided shared decision-making. So then you have to ask yourself, what is a favorable option? And this is very judgment-based. So it's based on evidence-based probabilities, if we have it, how much the benefit outweighs the burden, how much the burden maybe of the other one outweighs the benefit. It's also based on the physician experience. And then often, sometimes we look out to other people who may be experts in the field and ask for their opinion. And then there's also this physician's responsibility to public health. And that's something I think that we tend to not take into consideration as much as we probably should in these situations. So for instance, we're going to talk about a 4-year-old with E. coli UTI that could be treated with several antibiotics. So we're going to treat it, everybody's cool with treating it, but there's maybe 4 different options. Which one are you going to choose? So you look at the benefit burden to the child to decide, right? We do this all the time. How frequently is it going to be administered? Do they need to give it every 6 hours around the clock? That's really burdensome to the families. We look at side effect, profiles for each of these drugs. And if we're cognizant of this stuff, we look at the cost that this is going to be to the family. So we weigh all of these benefit burdens before we start making our recommendation of what antibiotic we're going to speak to. But then there's this benefit burden to public health. And so you take into consideration, so what if you have one antibiotic that can be dosed once a day? That's a really nice benefit to burden ratio for the family. But if that is a super broad spectrum antibiotic, that's actually a burden to the public health, because you want to choose the most narrow spectrum to decrease, antibiotic resistance, the most narrow spectrum. And so if the most narrow spectrum is every 6-hour dosing, you have to try to find a better maybe option that has both benefits to the public health and to the burden on the child. And I would say in the example that I shared at the beginning of, that child who the benefit, was you didn't have to live through your child dying, but the public health burden for her, she's institutionalized, that it's using a lot of resources. Right now, we can't find a bed in the state of Virginia to take some of our chronic patients who have to be institutionalized. I think the wait is 1.5 years. So we have at least 3 patients in the hospital right now that need to be sent somewhere. They cannot be taken care of in a home, and we cannot get them anywhere. That's a huge burden to the system, because choices were made to, do medical interventions for these children. Okay. So again, issues with the second step is that it's very subject and prone to bias, so we need to keep that in our minds, be very aware of that, and then we just talked about that. Okay, so we move on to step 3 once we've decided if there's, is this going to be physician guided, because there's a really strong option on one side versus going to parent guided on the other side. And now we're in step 3, which is how preference sensitive are these options. So this is where the patient, families, goals, all of those values come into play, and that helps you kind of go along this spectrum. So taking time allows you to ensure that the values and preferences that they have align with the choices that have been presented, in addition to the choice that ultimately is going to be made. It helps, it aligns with this bioethical principle of autonomy. As we spoke before, the parents are the experts, not only in what they want, but hopefully experts in what their child wants. Also playing a role is what all the interests of the family. So we often don't take into consideration the siblings, financial burdens for families and things like that. So all of those things the parents are experts at, and you really should spend time talking about that. And then this is what impacts how preference sensitive the options are for the families. So your role in this step is incredibly important, because we often skip this whole step. We don't spend time talking to families and finding out what their situation is going to be like, what this is going to look like if they're making this choice for some of the harder ones. And so your role is to slow down, learn about them, respect them, respond to their questions, ask them, if you hear something that you need to get more information about, to take them down that pathway. You can also help families kind of construct their preferences. If they say one thing and then they're like, but I'm leaning towards this, you can start saying, hey, but I thought that you said this was really important to you. How does that play into what you're talking about now? And then integrating those values that you learn about into your recommendations when they do ask you for a recommendation. They say that it's also really important, we are human, so we are going to have our preferences. And when they ask for your recommendation, your preferences are going to come out. And so it's really careful for you to communicate. Like if you say, this is what I think is the better option, that's your bias being applied, and you need to be very careful you're expressing it in a way that is not coercing them or manipulating them to come to your side. So simply eliciting parent values and preferences falls short of balancing patient autonomy and your obligation to promote the patient's health and well-being. So this step is actually designed to empower physicians and with our really important role of helping families make decisions. So problems with step 3, it takes a lot of time. And most of us do not have a lot of time. And so my recommendation is that if you're working with a family, you need to start some of these discussions really early. Spend as much time with them as you can throughout the course of any of these major decisions being made, because you need to earn their trust. That really helps as well. And then you have to be really careful about sharing your biases with them, even though it's important to express them. A lot of times we're afraid, we don't know how to do this without forcing them, and it's not something we're trained to know how to do. So a lot of doctors don't have the time, and we're afraid of this whole thing, and so we just skip over this step. But it's really critical to true shared decision making. And then once you've decided how preference sensitive those options are, it moves you one way or the other on the spectrum and takes us down to step 4. So even after you've done all of these things and, say you were moving towards physician guided, you still, once you get down to those actual decisions, can move along that whole entire spectrum. So preferences change, situations change, and doctors change as well through that whole entire process. So here's some examples that I was going to go through. Do we have time? Okay, good. So we have the option. So we have a patient with acute uncomplicated appendicitis. There's medical management for it or surgical management. So studies actually support in this situation surgical management actually has higher efficacy. There's a low rate of complications. And so according to this, these examples are taken from the article. These are not my opinions. So according to this, they would say that this is 2 medically reasonable options, but one has a higher benefit to risk ratio. And so this would move you down towards the physician-guided shared decision-making. But again, if parents have, if you get down there and you're like, no, we really think surgery is the best option, it's going to But if you have a parent that says, absolutely not, we cannot do this, I don't care if I spend, twice as long in the hospital, I don't care that he's going to have this procedure or that, like lines done and antibiotics for a long time, blah, 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 whatever it is, then that still has, even though you've gone down that pathway towards strong physician-guided, you can very easily, once you spend time talking to families, move more towards the parent-guided. And again, you may try really hard to persuade to move them back over to this side, but you have to be very respectful and ultimately come to a mutual decision at the end. Male newborn circumcision. 2 medically reasonable options. Should we circumcise, should we not? Some of you are like, no, there's not 2 medically reasonable options. Okay, so again, according to this article, there are. But this decision is very influenced by religious, cultural, and personal preferences, as we all know. So this is an example of moving towards the strong parent-guided shared decision-making model. But if they're not preference sensitive, it actually can move towards the weak end of this, and so then that's where your preferences or biases would come into play. So this just says that, you know, you can say that there's really neither option is better than the other. And then if parents don't have a strong preference, you can kind of help guide them and play a much bigger role in that decision. Okay, so really quickly, there's some decision aids out there that I think are just fascinating. So this is not really a shared decision-making model, but it gives families information and really tells you what you should be telling families when they're making decisions like this. So this is from Australia, and so I think it's really great because it goes through everything, like what causes the infection? How long do you think an earache is going to last? And so it really informs families. What are all the treatment options? So you can take antibiotics or you don't have to take antibiotics. And then it goes through what the benefits and harms are of each of those decisions. When I was in residency, which was the last time I did outpatient care for whether or not you should do antibiotics for an ear infection, I was always like, well, I don't think that it's an ear, a bacterial infection, but if you'd really like me to culture it, I could stick a needle in there and try it out. And then they were like, no, we'll just wait. So I'm kidding, of course I never said that. So then it tells you, okay, so how long would an earache last if I did antibiotics versus not? And the evidence shows that it's 12 hours less. And then it goes through the possible benefits of taking antibiotics. So again, it shows that out of 100 people or children, 5 of them would get better a little bit faster if they took antibiotics. And then it goes over the possible harms of choosing to take antibiotics versus not. And then, where does all this information come from? So you know why I'm offering you all this information, where it is, and why might you choose antibiotics? It describes what antibiotic resistance is, and what else can I do if I choose not to have to use antibiotics. What else can I offer my child to help them through this period? And then, when should I talk to my doctor? So I think that this is, and then it gives them questions to talk to their doctor. So, which I wish we had decision-making aids like this for everything, because if you could just say, well, here, why don't you go educate? Here's everything I was supposed to tell you, but I have 2 seconds to do it and I can't. So here's all the information. Now you can come to the discussion informed, and we can really talk about, what this means for you, how does this fit into your family, all that kind of stuff. So it just makes it really easy. And then this is just, I'm not going to go to it. We'll just skip past this, but this was, it's very similar. Mayo Clinic model for ear infections, and but it's online instead of paper form, and they can just click on different boxes and really inform themselves well. So we have 2 minutes for questions. Okay, the development of the doctrine of informed consent in medicine was driven primarily by physicians, states, and federal governments, courts, or consumer groups. CNC. Hopefully my words. Yes. C. Very good. Which of the following should be included in a shared decision-making model? Risks, benefits, understanding patient's value, advice from the physician, or E, all of the above. Very good. And last, the following is an example of shared decision-making. We can perform surgery or we can let your child die. Oh. Only the sick speak. hopefully that you all saw that in my talk that this would be false. That's not shared decision making at all. So, questions?
Oh, I want to make one comment. That was really good, thanks. You know, and I'm an old intensivist, and I guess I'm a less old general pediatrician. It's interesting, I was thinking about what are we doing in the office now that incorporates that model? And the two things that come to mind are vaccine hesitancy has declined, but I kind of lived through the peak of it in the kind of early 2000s. But that's still an area where parents don't always want to follow the recommendations. And so we have to negotiate a schedule that we're comfortable with and they're comfortable with. That still happens relatively regularly. And I think the other one that came to mind is treating mental health disorders. You know, what we do for ADHD, anxiety, depression, I mean, that area has just kind of exploded the last 5 to 10 years. And that's kind of a process too, depending on family resources, willingness to consider, you know, therapies besides going to medicines first. So those two areas are, I think, where we really are required to do that on a daily basis in the outpatient setting.
I actually found some decision-making aids for mental health, but the one that I didn't explore all of them, but the one I went into really was just a list of medications, and you could just go through to try to find which one would be the best for you. And I was just like, oh, really? Are we not presenting any other options except for these medications that often do not work really well? So.
There's the thought I had when you talk about surgeons and surgery versus palliative care for kind of extreme situations. Yeah, there's the issue of time that comes in the component of a lot of your work and surgeons' work. But is the issue of public health. If I'm a surgeon and we don't do this surgery, we'll never know how to do this surgery and make it better. And so that's kind of more of a broad look, and you'd say, why would I take that mindset with any individual patient family? The argument could be with, helping children with spinal muscular atrophy survive. Today, if we had the mindset that we had when I was beginning, take your child home, love them as long as you have them, versus let's help them survive with a miserable, potentially miserable existence, whatever bias you use to influence that statement, to where we are now, where we have options that can do real intervention. If we never take those steps, we would never have those steps.
I think that's a perfect example of why this is so hard, because we do all have our personal biases. And sometimes it makes it difficult for us to see the other perspectives of it. Absolutely.
It's also a struggle that so often the best thing for the individual versus the best thing from a public health population standpoint can be so different, that it's a real struggle when you form your conception as a physician based on more or less what the public health view is. I want all children to be immunized. But then on the individual level, you have to work with those people based on their own families' values and beliefs, and and working within those confines, and that sometimes even what you would pick for that individual might be different. The antibiotic choice, the most narrow is the best for the public health, but the ampicillin dose Q6 hours versus Omnicef once a day. For a kid that has a full-blown temper tantrum, et cetera, when you try to give them the medication, you're going to sympathize with the parent and probably give them the antibiotic dose less frequently.
Absolutely.
I think that's what's nice with the time-based sort of things. I know there's the limitation of sitting down that one time and spending half an hour talking through things, or whatever time that might be, but also the perspective of time. Like you talk about, they first come in, you kind of recap, you touch base again in a few days, a few weeks. So shared decision making.
And now they have mastoiditis.
Right.
Right, exactly.
Revisiting those kind of issues and making sure that, this is where we are now. does that change where you stand with things? So like vaccines in particular, I think that's helpful too. Okay, we won't talk about it today. Let's talk about it at the next visit.
That's where the primary care doctor is so important to long-term care decisions with handicapped children, is that you have the ability to bring that up when the child's relatively healthy and maybe on a positive trajectory, but presenting that this may be the end point where we're hitting them at the very end where we don't have time to discuss it. The family, if it's not been brought up previously, hasn't spent the amount of time they should have, maybe delving into risk benefits of various treatments that may not have a strong body of evidence that they're going to help with that, do everything. And I think a lot of both on the physician side and the patient side, when it hasn't been thought out and discussed ahead of time, we default to the do everything, even if there's no evidence that it's going to help. Where if the family has had that discussion with their PCP that, my child's life expectancy is going to be shortened, but, the SMA child, there is the option of a trach and a ventilator versus I'm only going to do non-invasive ventilation, et cetera, that, if they've thought those things out ahead of time, they're able to make a clearer decision with more evidence that supports their beliefs for their child and their wishes for their child. So it is helpful when families have thought about and addressed these issues over time. And in, maybe it's in small bits where the family needs time to make those decisions clearly.
Two other comments. One is that, we'd like to consider that we're changing our mindset through time as physicians and learners in medicine, but we're trained to be manipulative people. We are trained to give our opinion and have it followed.
Yeah.
And so we have to think.
Autonomy dies hard.
So, and so we have to grapple with that. But also I think about who is influencing our decisions along these lines from individual patients, population, public health. It's not as much the physicians nowadays, and we need to look at that. And if we look at it from the perspective of this process of shared decision-making, if you bring all components to the table, then maybe we have some reasonable, chance of having discussions rather than, politicizing, public health issues. So, unfortunately, you can find, if you put a room of 5 physicians in, you'll get 5 different opinions.
100%.
So, that's the other aspect of that. And when physicians don't agree on the decision-making outcome, we influence with our biases. And so, the example is when I was in Cincinnati Children's as a fellow in the ICU. One of my fellow fellows was charged with taking care of, as we were wheeling in a 10-year-old child with, after their second bone marrow transplant and sepsis. And this physician was from Scotland. She said, this would never be happening in my country. And the department chair of oncology said, why would you not do everything you can for this child? So that's where we're at, particularly in hospital medicine nowadays.
Well, that brings the point of, to what extent should the public or patients be aware of the potential consequences to us when we don't get to do the surgery and don't get the training and or are liable and then sued for not doing something that we didn't really want to do, but that we'd be scared that the families didn't have that option, like the bilateral, hemicraniectomy. Did I say that right? Bilateral craniectomy. It's not hemi anymore. To what extent do they need to know that could we be sued if we don't pursue an option that we don't at all agree with that's left this child comatose? So I don't know the answer to that, but.
It's complicated, right? All of this is complicated because even when we do due diligence and do it as best as the best that we can, you can't always, you're always at risk. It's what we chose to do for a living. So.
One thing that's unique to our country is we continue to behave like medical resources are unlimited.
Yes.
And that's not the case in pretty much every other, industrialized, developed country in the world. And at some point, I keep thinking at some point we'll have to, but I said that 30 years ago, and it hasn't really changed, so.
I'll tell you, one night when I was in a crisis situation and we could not find a yonk hour, I was trying to losing it. Yeah, it's just, we are moving to a place where our resources are not what they were 5 years ago. And it's very difficult to practice the same medicine that we practiced 5 years ago.
Thank you.